Good morning, everyone. Welcome to another episode of Free Knowledge Academy weekly Sunday CPD webinar series. Today, we have a very interesting topic, the menopausal transition. Before we go on to the topic, let's go to see some housekeeping rules. The webinar link will be available for you to join in from 9 to 9:45 a.m. No late attendees will be permitted. Please keep your mics and videos turned off during the lecture. You can raise your questions and you can type your questions in the chat box and make sure you change the settings for your question to be seen by all the panelists and the attendees. And of course, you can ask your questions at the end of the lecture live from the lecturer. One should be admitted, one should be attended for the whole lecture for 1 hour duration to collect the CPD points and the e-certificate at the end of the lecture. The link for you to obtain the e-certificate will be put at the end of the lecture in the chat box. Now, let's go to our today's topic, the menopausal transition. A word about the lecturer before going on to the lecture. Today the lecturer is Dr. T. Suhajanan Thevaraja, who is the consultant obstetrician and gynecologist at the District General Hospital, Mullaitivu. He obtained his MBBS from the University of Jaffna in 2009 and completed his MD in Obs and Gynae in 2019. Then he completed his foreign training in Australia and currently working as the consultant obstetrician and gynecologist at the DGH Mullaitivu. Dear sir, over to you to conduct your timely lecture. Thank you very much.
Good morning, everybody. I'm Dr. Suhajanan Tavaraja, one of the obstetrician and gynecologist currently working in Mullaitivu. I would like to thank Sri to give this tremendous opportunity for me. And I hope we may have learned something new today, which area is quietly ignored, but important in a woman's life. So here we are going to learn regarding the menopausal transition and its physiological stages and also some treatment options. So first of all, we have to start with the definition and terminologies because with the time, so almost all the definitions in obs and gynae going to change. So previous definitions are very chaotic and somehow confusing. So now, so even in the postmenopausal bleeding and even in the abnormal uterine bleeding, all areas in obs and gynae, terminologies are keep on changing. So as usual, we start with the definition. The menopausal transition is a progressive endocrine continuum that takes reproductive age women from regular, cyclic, and predictable menses that are characteristic of ovulatory cycle to a final menstrual period associated with ovarian symptoms. So usually we all know menopause refers to a point in a time that follows 1 year after the cessation of menstruation. The postmenopause means it describes in those years following the final periods. So final menstruation. So average age of a woman experiencing their final menstruation period is 51.5 years. And premature ovarian failure, this is a new terminology and refers to cessation of menses before age 40 and is associated with an elevated follicular stimulating hormone levels. All the terms perimenopause or climacteric generally refers to the time period in a late reproductive years, usually late 40s to early 50s. Characteristically, it begins with menstrual cycle irregularity and extend to 1 year after permanent cessation of menses. So more correct terminology for this time is menopausal transition. So as we know, the menopause is not a point diagnosis. It's a period of time. So in women's life, they experiencing transition. It's almost 10 to 15 years. Say sometimes it may start from early 40s. Sometimes it may start from middle 40s. So in that point of period, they experiencing there are so much of body and systematic changes and even the psychological changes. So the main target of these presentations, how they are going through this transition and how we can improve their overall health during this transition. So this transition typically develop over a span of 4 to 7 years, and average age at its onset is 47 years. So stroke, this may new for you all. Stroke means this is the first standardized classification guidelines for female reproductive aging. This was proposed in 2001 at the stages of reproductive aging workshop. So stroke means stages of reproductive aging workshop. So these, so yeah, and so this is the the stages of reproductive aging workshop classification. So this is a now currently the obstetricians for managing the perimenopausal and menopausal symptoms, we are using these classifications, stroke classification. So mainly this has come from the one of the Canadian paper. And America is almost adapted to these, but in Sri Lanka, because of lack of facilities, we are not still using this one because we don't have the sophisticated HRT modalities here. So here we can see the stages. There are 4 stages, 3 stages in reproductive age, and 3 stages in the 2 stages in the menopausal transition, and 1 in a postmenopausal period. So that means, so in the point in between the -3 to -2, we expect the menopausal transition is started, and then between the -1 and the +1, the point is the final menstrual period, and then after that period, the postmenopausal. So here, why this is important? Because a lot of symptoms can start from this late reproductive age, or maybe from the early menopausal transition, maybe from -3 or stage 4, -2. It's continue for 5 to 7 years or 7 to 10 years up to the postmenopausal period. So that's why this straw is important. So we can use this straw to recognize the symptoms, and we can categorize the patients whether the menopausal area or the perimenopausal area, whether the patient is in the perimenopausal area or menopausal area. Treatment is still same, but the risk of having the other health risk is high in the postmenopausal area. So we can balance the treatment if we remember these straw classification. So here you can see as usual, the reproductive stages, the duration is very variable, and the menopausal transition is also variable, and postmenopausal, we all know the stage +1 is lasting for fairly 1 to 5 years, and +2 is until demise. Okay, so overall physiological changes. So overview of physiological changes. So, with a withdrawal of single hormone, the women in their life, they experiencing a lot of benefit to, it's a balancing thing. Sometimes it may causing harm to the health, and sometimes it may causing benefit to the health. So we can see one by one. So in overview of physiology, there are, as we know, hypothalamus, pituitary, ovarian axis changes, then it may go to the ovarian changes, then adrenal steroid changes, obviously endometrial changes, and fertility potentials changes, and contraception during that period. It's central thermoregulation changes, bone metabolism, and their structural changes, cardiovascular changes, and central nervous system changes. So we can see one by one. So hypothalamus, pituitary, ovarian axis changes, how it can happen. So during reproductive age, GnRH, gonadotropin releasing hormone, usually secreting from arcuate nucleus of the medial basal hypothalamus in a pulsatile fashion. So these pulsatile secretions of GnRH go to cyclical release of FSH and LH from pituitary gonadotropins. So these gonadotropins, so FSH, LH, these gonadotropins stimulate the production of ovarian sex steroids and inhibit. So regular and predictable menstrual cycles we can expect. In early menopausal transition, a level of FSH rises slightly and lead to an increased ovarian follicular response. This in turn creates overall high estrogen level. And also, testosterone levels do not vary appreciably during menopausal transition. Anti-Mullerian hormone it's a glycoprotein secreted by the granulosa cells of secondary and preantral follicles. Circulating concentrations of anti-Mullerian hormone is relatively stable across the menstrual cycle in reproductive age women and correlate with number of early antral follicles. Here, we can, I think sometimes you may heard the ovarian reserve. So here, we use this anti-Mullerian hormone to predict the ovarian reserve, especially for the subfertile girls. They are coming for the consultation with us. We might have to do anti-Mullerian hormone to predict their ovarian reserve. A level of anti-Mullerian hormone decreases markedly and progressively across the menopausal transition, because during the menopausal transitions, the women, they are losing a lot of preantral follicles or secondary follicles. So they losing a lot of granulosa cells. So they are losing the anti-Mullerian hormone, and they are losing the fertility potential. So reproductive age ovary, you can see there are a lot of antral follicles, and the second ovary is a postmenopausal ovary. Here, the loss of all the preantral, antral, and secondary follicles, all the stroma is replaced with a fibrous tissue. So ovary is there, but we can say non-functioning ovary. Sometimes it may secrete some testosterone, but still it's working, but not up to the level of reproductive age. So from birth onwards, primordial follicles are continuously being activated, mature partially, and then regress. Sometimes it matures to the secondary follicle, Graafian follicle, and ovarian. So this follicular activation continues in a constant pattern that is independent of pituitary stimulation up to the preantral follicle, or maybe some part of antral follicle. A more rapid depletion of ovarian follicles starts in late 30s and early 40s and continue until a point at which the menopausal ovary is virtually devoid of follicle. So almost we can expect around 400 ovulation during reproductive age time. So how the adrenal steroid changes during the menopausal transition? So dihydroepiandrosterone steroids produced almost exclusively in the adrenal gland. With advancing age, so adrenal reproductions decline. So DHA's concentrations peaked during reproductive years with an average of 6.2 micromole and then decreased steadily. In women with 70 to 80 years, DHEA's levels were diminished by 74% to 1.6 micromole. So other adrenal hormones decreases with aging as well. So androstenedione peaks at ages 20 to 30 years and then decreases to 62% of the peak level in women age for 50 to 60 years. Pregnenolone diminished by 45% from reproductive life to menopause. So how these all ovarian changes and hypothalamic pituitary adrenal axis changes, and also the hormones coming from the ovarian changes bring to the endometrial changes. So during the later stage of menopausal transitions, anovulation is very common, and the endometrium will display estrogens effect when unopposed by the progesterone. Accordingly, the proliferative changes or disorder proliferative changes are frequent finding on pathological examinations of histopathological examinations of endometrial biopsy samples. After the menopause, the endometrium become atrophic due to lack of estrogen stimulation. So you can see all these pictures here. The first one is a proliferative endometrium, lot of stroma, 1:1 ratio, maybe 1:1 glandular stroma ratio, and the second one is a secretory. So more glands, more complex glands, and minimum stroma. And the pregnancy, this deserialized endometrium, and the fourth one is a inactive endometrium after the menopause. So a lot of stroma, very minimum glands. Fertility potential, contraception, yes, because ovulation is happen, but it's not predictable. So that ovulation can bring the pregnancy. So contraception, yes, but cautious regarding the hormonal contraception. And sometimes the subfertile girls may have a consultation with obstetricians after their menopausal transition. So assisted reproductive techniques may be helpful for them. central thermoregulation. So the key of this presentation. So what is the incidence? What is vasomotor symptoms and why that is happening? So what's the function of central thermoregulation changes bring these vasomotor symptoms, and what are the impact on the woman's life? So the incidence wise, these vasomotor symptoms may be described as hot flushes and night sweats, a main uh, complaint of the menopausal transition uh, women. In around 11 to 60% of the menstruating women during the transition, they have vasomotor symptoms. And in a study, that Manchester Women's Health Study, the incidence of hot flushes increased from 10% during the premenopausal period to approximately 50% after cessation of menses. And hot flushes begin an average of 2 years before the final menstrual period, and 85% of the women who experience them will continue to experience them for more than 1 year. Of these women, 25 to 50% will have hot flushes for 5 years, and 15% may experience them for 15 years. So almost we can say in a woman's life they experiencing the hot flushes for 15 years. So what is vasomotor symptoms? So hot flushes means a sudden increase of a skin temperature because of the peripheral vasodilation. It's generally last 1 to 5 minutes. Sense of a sudden wave of heat that spreads over the body, particularly on the upper body and face. And sweating begins primarily on the upper body. Sweating has been observed in a woman during 90% of the hot flushes, and increases in both awake and sleep systolic blood pressure are noted with the hot flushes, and heart rate increases 7 to 15 beats per minute at approximately the same time as peripheral vasodilation and sweating. Now you can understand how annoying this one in a woman's life. Suddenly they have some heat produced in the body, mainly upper body and the face, and they feel the hot in the body, and then they feel the increasing heart rate and the high uh, systolic blood pressure, increasing systolic blood pressure. So this is the pathophysiology of vasomotor symptoms. You can see uh, in premenopausal state, what will happen? The estrogen, so the culprit hormone coming from the adrenal and ovary, working on the hypothalamus. So because of the very sophisticated neuronal signals and the physiology of the body, the happy hormone serotonin will coming out. This serotonin is working on the 5-HT receptors. One is responsible. 5-HT receptor 1A is responsible for the hypothermic response, and 5-HT receptor 2 is responsible for the hyperthermic response. So here, the releasing serotonin from the presynaptic neuron act on both receptors. This balance is very important to make the normothermic, so euthermic environment of the body. So what will happen? This 5-HT, that means serotonin, it's balancedly act on the 5-HT receptor 1A and 5-HT receptor 2, and combined with the external factors, normal thermoregulatory responses take place, and woman is an euthermic during the premenopausal state. So what happened in the perimenopausal or postmenopausal state? Same estrogen, now in a same amount of estrogen in different concentrations, maybe in a high concentration or maybe in a low concentration. So the system in the hypothalamus is now dysregulated. So serotonin is coming, but we don't know, it may be the maybe in a high concentrations or low concentration. But here the main thing is happen the receptors. So 5-HT receptors level is going down because of the withdrawal of estrogen stimulation, but 5-HT2 receptors is going up. So what will happen? Because of the high 5-HT2 receptor levels, a lot of serotonin working on that, combined with the external factors, altered thermal regulatory responses take place, hot flushes. happen. So this is you can see. So this is a subsequent or pharmacological treated postmenopausal uh, state. So here, what will happen? We are giving estrogen, progesterone, and some uh, non-prescription medication, prescription medications, and estrogens all coming together and work on the hypothalamus. Now, what will happen? That will upregulating the 5-HT1A receptors, and yes, of course, 5-HT2 receptors also, but uh, the upregulatory potential for the 5-HT1A receptor is higher than the 5-HT2 receptors. So here, the more serotonin act on the 5-HT1A receptor. So with external factors, normal thermoregulatory response happen. So euthermia. So sleep dysfunction and fatigue. So sleep dysfunction usually it's another main complaint from the perimenopausal or postmenopausal ladies, the woman who is in the menopausal transition. One is the vasomotor symptoms, obviously, and second is the sleep dysfunctions and fatigue. Maybe the vicious cycle. So sleep dysfunctions and fatigue happen, and also because of that, the patient may have the altered thermoregulations, and they have more and more uh, vasomotor symptoms. Then because of the vasomotor symptoms, the lot of heat waves and sweating cycles and end up with the sleep dysfunction and fatigue. So it's a common complaint. And difficulties in sleep onset and sleep maintenance are the common problems in menopausal women. Sleep fragmentation is commonly associated with hot flashes, and disturbed sleep can lead to fatigue, irritability, depressive symptoms, cognitive dysfunctions, and impaired daily functioning. So prevalence was studied in a research. So sleep disturbances ranges from 32 to 40% in early menopausal transition, and from 38 to 46 in the late menopausal transition, almost 1 in 2 women. So many women begin to have prolonged feeling of fatigue, exhaustion, and lack of energy during menopausal transition. Okay, now we can move into bone metabolism and structural changes. So as we know, the bone is a dynamic tissue, and constantly it's forming and reabsorbing by the cells in the bone environment. So the constant bone changes is happening in the body, but in a balanced state. If the balance is tilted towards bone formations, more bone form, or bone resorption, more bone, we may lose a lot of bones. So bone remodeling, the amount of bone at any point in time reflects the balance of osteoclastic and osteoblastic activity. So we know osteoblastic cells is responsible for the building of bones, and osteoclastic cells responsible for resorbing. So this balance is influenced by a multitude of stimulating and inhibiting agents. Those are, both aging and loss of estrogen lead to significant increase in osteoclastic activity. In addition, a decrease in calcium intake or impaired absorption of calcium from the gut lowers the serum level of ionized calcium. So this lowers the level of serum ionized calcium to stimulate the parathyroid hormones secretions to mobilize calcium from bone by stimulating the osteoclastic activity. So these process significantly increase the parathyroid levels and from the production of vitamin D in turns increases the vitamin D levels due to elevated serum calcium levels by several effects. First, the stimulating osteoclast to remove calcium from bone and increasing intestinal calcium absorption and stimulating renal calcium reabsorption. So these cycle is constantly happen in the body, even the male also. But in the female population, there are some regulatory proteins are there, like osteoprotoglandin, RANG ligand. So these all three is influenced by the estrogen. What will happen if the estrogen dominant body environment, the osteoclastic activity osteoblastic activity is augmented. So balance more towards the osteoblastic activity than the osteoclastic activity. But the loss of estrogens will lead to activate the bone resorbing side. So the more bone we are losing from the body. So by understanding the physiology, we already discussed why we can say what is osteopenia and osteoporosis. So osteoporosis is a skeletal disorder that compromise bone strength due to a progressive reduction in bone mass, typically grating trabecular bone. Osteopenia is a precursor of osteoporosis, uh, and estimated number of individuals with osteoporosis or osteopenia continues to increase. The National Osteoporosis Foundation, US, estimates that more than 10 million Americans currently have osteoporosis, and another 33.6 million have osteopenia on the hip. In a white woman, age 50 years, epidemiological studies from North America have estimated the remaining lifetime risk of common fragility fractures to be 17.5% for hip fracture and 15.6% for clinically diagnosed vertebral fracture and 16% for distal forearm fractures. And these figures are almost reflecting the world trend, but sometimes the South Asian country may have a little bit of high risk of osteopenia, osteoporosis because of the lack of calcium in the food or because of our food habit. But these epidemiological studies is more or less reflecting the world's trend of osteopenia and osteoporosis. So how we can diagnose osteoporosis? Bone mineral density. So we can assess the bone mineral density with DEXA. DEXA dual X-ray absorptiometry, and usually we are doing DEXA of lumbar spine, radius, and hip. We all know the body usually have trabecular bone and the cortical bone. The trabecular bone, it's around 20%, comprises 20% of the skeletal weight, and the cortical bone is denser and more compact bone and comprises around 80% of the skeletal weight. The created trochanter and the femoral neck contain both cortical and trabecular bone, and these sites are ideal for the prediction of hip fracture risk in older women. They increase parathyroid hormone synthesis from that expected for a person for same sex at peak bone mass. It's a comparison. So criteria for interpretations of the bone mineral density. This area it may be useful for the general practitioners in the community. Normal BMT is defined as T-score between plus 2.5 and minus 1. So as such, the patient's BMD lies between 2.5 standard deviations above the young adult mean and 1 nesty below the young adult mean. Osteopenia, then is low BMD, is associated with the T-score between 1 and minus 2. Inclusive, both plus minus 1 and minus 2.5, both inclusive. Osteoporosis is defined as T-score lower than minus 2.5. This data also taken from the National Osteoporosis Foundation US from 2010. So cardiovascular changes. The relationship between the menopause and cardiovascular disease incidence was first examined in the Framingham cohort of 2,873 women. So there was a trend for a 2 to 6-fold high incidence of CVD in postmenopausal women compared with the perimenopausal women in the same age range. So these and other data indicates that withdrawal of estrogen may be associated with the increased risk of CVD, but still we don't have we don't have the clear evidences for that. But with the aging process and withdrawal of estrogen, maybe the increased risk, maybe. And dermatological, dental, and breast changes and hormonal aging of the skin is thought to be responsible for many dermal changes. These include a reduced thickness due to diminished collagen content, a decrease in sebaceous gland secretion, loss of elasticity, a diminished blood supply, and epidermal changes. So dental changes, the buccal epithelium undergoes atrophy due to estrogen deprivation, resulting in decreased saliva and sensation. Breast changes at menopause, withdrawal of estrogen and progesterone lead to the menopause. So breast changes at menopause, withdrawal of estrogen and progesterone leads to a relative reduction in the breast proliferation, a significant reduction in the volume and percentage of a dense tissue on mammography, and these areas become replaced with the adipose tissue. Central nervous system, so sleep dysfunctions we already discussed, and cognitive dysfunction. Here in cognitive function, the researcher says the withdrawal of estrogen is a minimum effect on the cognitive decline. But a lot of others are saying the normal aging process is a main reason for the cognitive dysfunction. So we will discuss later in the HRT section also. HRT, it's failed to increase the cognitive function to the woman who treated with HRT. So so that may compatible with the other statement that aging process is the main culprit for the cognitive dysfunction. And memory decreases with advancing age, although no direct effect on lowered estrogen level on memory and cognition has been determined. Many investigators suspect a relationship to or an acceleration of cognitive decline during menopause. Urogenital changes, thinning of urethral and bladder mucosa may lead to urethritis with dysuria, to urge urinary incontinence and to urinary frequency. In addition, urethral shortening associated with menopausal atrophic changes may result in stress urinary incontinence. For example, Matthew and colleagues showed that estrogen therapy, so local estrogen therapy, may improve acute stress urinary incontinence in more than 50% of the treated women. Accordingly, a trial of hormone therapy should be considered in selected patients prior to surgical corrections of incontinence in women with vaginal atrophy. So the patient evaluation. Now, I hope you must understand the physiological changes happen during the menopausal transitions, because once we understand the physiological changes during the menopausal transitions, then treatment is easy. So we simply can determine what is the complaint, okay, what is happening behind the scene, so how we can treat the patient. So, but unfortunately, we don't have much modalities in Sri Lanka, but as per our resources, somehow we can manage the menopausal transition. So patient evaluation. So first of all, always when we are managing patients, we always think about a differential diagnosis, because uh, menopausal symptoms is usually, sometimes, not usually, sometimes it may be a symptoms of the severe systemic illness. So if the patient is complaining of hot flushes, vasomotor symptoms, we have to think about hyperthyroidism, pyrocytoma, febrile illness, anxiety, or psychological symptoms. And same as if vaginal dryness, dyspareunia, bacterial vaginosis, yeast infection, pelvic pathology, with poor vaginal lubrication, and marital discord, all those things we have to consider. Primary osteoporosis may be osteomalacia, primary and secondary hypoparathyroidism, hypothyroidism, or excess thyroid replacement, excess corticoid therapy, and increased calcium excretions. Abnormal uterine bleeding may be due to anovulation, endometrial cancer, cervical cancer, endometrial hyperplasia, endometrial polyps, a uterine leiomyoma, urogenital atrophy, and hormone replacement or hormone treatment, obviously. Okay, so what are the clinical goals in patients' evaluations? So goals are uh, optimizing a woman's health and well-being during and after the menopausal transition. So, and also, this is an excellent time for a detailed health evaluation, including a complete medical history, physical examinations, and laboratory studies. So, meantime, we can assess the risk factors for common health problems such as obesity, osteoporosis, heart disease, diabetes mellitus, and certain cancers. And counseling regarding diet, exercise, alcohol, maybe or maybe not, and smoking cessation, same, maybe or maybe not. And physical examination, the constitutional examinations like height, weight, BMI, and questions about the physical exercises and weight loss or weight gain uh, things, and assessment of weight distribution, waist circumstance, and identifying the truncal obesity. Height loss, it's very important because it may be the presentation of osteoporosis of spinal compression fractures. Therefore, yearly height measurement is very important. And blood pressure monitoring, effectively screening the hypertension. And cognitive decline, uh, yeah. So the cognitive decline is unusual, but forgetfulness or scattered thinking may be part of normal aging. And patients who are concerned about cognitive decline, brief screening test can be used. And psychosocial evaluations, uh, and simply the GPs, even the obstetricians, simply uh, evaluate the patient psychosocially. It's simple by the few direct questions regarding depression, anxiety, sexual functioning. Then dermatological skin changes associated with the estrogen deficiency, including skin thinning and wrinkling, and and a careful inspection for abnormal navy uh, or the excessive sun exposure uh, may prompt a referral to the dermatology for further skin cancer evaluation, breast examination, vulval and vaginal examinations. So the pelvic examination. So for each and every patient, so they are coming with a menopausal symptom. So we should do a pelvic examinations. It's very mandatory to explore the uh, unusual abdominal masses and the uh, cervical cancer and abnormal cervical things. So simply digital vaginal examination and a bimanual examination and a speculum examination. So it's all simply it's enough to evaluate the pelvis. So with the vaginal examinations, you can say, okay, the vaginal lubrications and dryness of the vagina, atrophy of the labia minora, labia majora, and atrophy of the Montpellier, hair distributions. And then with the bimanual examination, simply we can say any pelvic or intra-abdominal masses, and also cervical examination is simply revealing the cervical pathologies. You can simply visualize the cervix and say, okay, whether cervix is healthy or non-healthy. So you need a more prompt treatment or the evaluation. So laboratory testing, usually if we find any other health related comorbidities. So like hypertension, cardiac disease, or maybe osteoporosis, and more sophisticated investigations may needed. In that case, we may get the help from other clinical personnel, so like BP, orthopedic surgeons, and maybe from a general surgeon. But in the terms of diagnosing the menopausal transition or postmenopause, usually it's a clinical diagnosis. But anyhow, to make sure this is okay, especially in early 40s, premature ovarian failure, sometimes we may need a gonadotropin levels or estrogen levels to diagnose the menopausal transition. So gonadotropins biochemical changes may be evident prior to the cycle irregularity, and FSH level greater than 40 has been used to document ovarian failure associated with the menopause. Estrogen level, estrogen may be normal, elevated, or low, depending on the stages of menopausal transition. Additionally, estrogen levels may be used to assess the woman's response to hormone treatment. Okay. Non-hormone prescription. Especially non-hormone prescriptions we use to, especially for the vasomotor symptoms and to improve the sleep cycles and to improve their overall health. So usually this is for the patients with contraindications to hormone therapy, or those who prefer alternatives to menopausal hormone therapy, and non-hormonal prescriptions option have shown some efficacy in the relief of vasomotor symptoms. These included selective serotonin reuptake inhibitors and serotonin non-epinephrine uptake inhibitors, SNRIs and SSRIs, gabapentinoids, clonidine, and oxybutynin. And none of are as effective as estrogen, and the response rate among women is very variable. So antidepressants. So efficacy of antidepressants for the reduction of hot flushes may vary from 27 to 61%. So almost we can treat two-thirds of the female populations who are having the hot flushes by these antidepressants alone. So although antidepressants are are moderately effective for the treatment of asthmatic symptoms. Adverse effect of SSRIs and SNRIs we know in nausea, headache, dizziness, dry mouth, insomnia, and nervousness. So we might have to educate the patients who are having vasomotor symptoms and who are willing for the SNRIs or SSRIs regarding these uh, adverse effect. So contraindications to SSRIs and SNRIs include prior neuroleptic syndrome or serotonin syndrome and concurrent use of monoamine oxidase inhibitors. So caution is also advised in regard to possible interactions with other medications and concurrent use of other SSRI and SNRI, especially in women receiving tamoxifen administrations of paroxetine or fluoxetine, which are potential inhibitors of the enzyme cytochrome P2D6, may reduce the formation of active metabolite of tamoxifen. Endoxifen is an active metabolite. So fluoxetine is available and adverse effect profile is reasonable. So gabapentinoid. Gabapentin and we know anti-epileptic drug has been found in trial to improve bothersome vasomotor symptoms, reducing hot flushes frequently by 45 to 71% from baseline. Adverse effect, again, the dizziness, unsteadiness, drowsiness, which tend to improve within 1 or 2 weeks. That's benefiting the gabapentin. So gabapentin may be a good option for women with sleep disturbance from vasomotor symptoms because drowsiness is a side effect. So the suggested dosage of gabapentin based on the clinical trial is 900 milligram daily in 3 divided doses. So in practice, some clinicians starts gabapentin at 200 to 300 milligram at night and increases doses in increment of 100 milligram every 3 to 4 days until a maximum dosage of 900 milligram nightly is reached. Another carbametinoid, pregabalin, may be effective in relieving hot flushes, but it is less well studied and less commonly used for vasomotor symptom. Clonidine. Clonidine is a centrally active alpha-adrenergic agonist that has been shown to be moderately more effective than placebo, but less effective than SSRI, SNRI, and gabapentin for a release of vasomotor symptom. So clonidine may be administered orally at a dose of 0.025 milligram or 0.05 milligram twice daily. Adverse effects include dizziness, dry mouth, and hypotension. Oxybutynin. Oxybutynin is an anticholinergic agent. Typically, we use these for the urinary incontinence, and that has also been shown to reduce vasomotor symptoms. So the patient who having urinary incontinence, urgency urinary incontinence, and the vasomotor symptoms, oxybutynin is a good choice for them. So it shows significant reduction in vasomotor symptoms was seen in a randomized controlled trials of extended release oxybutynin 15 milligram once daily in naturally postmenopausal women. In another study, immediate release oxybutynin at a dosage of 2.5 milligram or 5 milligram twice daily significantly reduced the severe vasomotor symptoms in patients with breast cancer. And also we have to consider the adverse effect also, dry mouth, gastrointestinal upset, constipation, blurred vision. Those are the common adverse effects. So here in this table, we can see the in SSRI, SNRI, venlafaxine, desvenlafaxine we can use for the vasomotor symptoms, but unfortunately this is not available in Sri Lanka. And SSRI, so paroxetine, citalopram, escitalopram, we can use all these three. Gabapentin is best choice than the pregabalin, and clonidine, oxybutynin. So oxybutynin, clonidine is available, gabapentin is available, and the other SSRI also available. So I'm not sure about the venlafaxine. I'm not using that. Okay. So non-prescription option, between 50% to 80% of the women in North America use non-hormonal therapies for vasomotor symptoms. Unfortunately, we don't have any uh, data from South Asian countries. So these are the lifestyle modification. I don't know how we can adapt on these and how we can advise the patients what with the busy schedules and things. I don't know how they are uh, adapt on the lifestyle modifications, but it's still beneficial. So cooling techniques, uh, evidence is limited, but reasonable to recommend it. Avoiding triggers, and they have to maintain a diary, trigger diary. So then it's very possible to avoiding the triggers. Exercise, yoga, weight loss, cognitive behavioral therapy, mindfulness-based stress reduction. So maybe uh, mm, uh, the laughing classes, things, and face respirations, relaxations, clinical hypnosis, acupuncture, and massages. And natural health products. Soy, it's freely available. So we can use the soy because the phytoestrogen contains isoflavins. Isoflavins, uh, it's around 50 to 60 percentage potent like natural estrogen. So when we are taking more and more soy, and it may help to reduce the vasomotor symptoms. Uh, in the other herbal products, evening primrose oil is available in Sri Lanka, and compared with the placebo, the it has some effect to prevent the vasomotor symptoms. And ginseng, the other herbal products, I don't know, black horse, it's available in other countries, but I don't know the availability in Sri Lanka. Okay, so the hormone replacement therapy. So the hormone replacement therapy. So I prepared this PowerPoint presentation so with the latest evidence on TOG and very latest the American and Canadian guidelines. So we all know the hormone replace. We just when the reproductive age woman, we have plenty of estrogen, but when the hormonal menopausal transition starts, we losing their estrogen concentration slowly, and once the menopause reach the ovarian estrogens, we might have to lost to up to 0%. So as we know so far, because of these uh, loss of estrogen, there are a lot of health hazards happen. So how can we reverse all these health hazards by replacing the hormone? That is called hormone replacement therapy, or maybe menopausal hormone therapy. So there are few modalities of hormone replacement. So we can see one by one. And also in GP setup and general practitioner setup also, we may introduce some kind of hormone replacement to the ladies needed one. Suffering with the vasomotor symptoms and sleep disturbance, cognitive dysfunction, and those things. So estrogen and progesterones are the main hormones we are going to replace. So estrogens, there are estrogen therapy can be delivered, and systemic estrogen is available, oral, transdermal, or subcutaneous implants. Transdermal preparations may be patch, gel, or spray. So each route follows a different metabolic pathway and therefore confers advantages as well as potentiating risk associated with the intake, each and every modality. So transdermal administrations of estradiol results in slow systemic release and avoid the first pass liver effect associated with the oral intake. So patches contain estradiol dissolved onto an adhesive matrix. Depending on the matrix used, these patches have to be changed once or twice a week, and serum concentrations reach a steady state, often within a few days. So local estrogen, topical vaginal preparations. Low vaginal estrogens delivery preparations include estradiol tablets and low-dose estradiol releasing rings made from a silicone that requires replacing every 3 months. While estradiol comes in a cream, pessaries, and gel preparations. All low-dose estradiol preparations are considered equally effective and do not result in significant systemic absorption and can be used long-term. So recommended changes in practice. So these recommended changes is from the one of the Canadian paper. And menopausal hormone therapy can be safely initiated in women without contraindications who are less than 10 years post-menopause or younger than 60 years of age. There is no specific time frame for duration of systemic menopausal hormone therapy, and treatment duration should be individualized. So contraindications, undiagnosed abnormal vaginal bleeding, known suspected or history of breast cancer, known or suspect estrogen-dependent cancers, coronary heart disease, active or history of venous thromboembolism, active or history of stroke, known thrombophilia, active liver disease, known or suspected pregnancy. And contraindication for progesterone, undiagnosed abnormal vaginal bleeding, current or history of breast cancer. So this is a flow chart, how we can approach a patient who seek for a hormonal therapy. So first of all, so actually for the hormone replacement therapy or menopausal hormone therapy, we need to assess the patient one-to-one. So I think in a busy clinics and with 100 of patients, assessing the patient one by one is very difficult. And also the knowledge regarding the hormone replacement therapy among our population is also very minimum. Some educated population, they are really straight away they are asking for the hormone replacement. So in that case, what we are doing usually counseling. So we are discussing the pros and cons and consequences of the hormone replacement, and discussing with them what are the special precautions we are taking, and its main thing is find out the contraindications. Then indication of hormone replacement therapy, if the patient is seeking or if the patient is symptomatic, we can offer the hormone replacement for all the women who don't have contraindication. So in that case, how we are deciding the mode of hormone delivery. So two things very important. If the patient is having intake uterus, the different modality, and if they have a hysterectomy, so the different preparations we can offer. So if the patient who having the intake uterus with a regular bleeding, postmenopausal symptoms, usually HRT is not recommended. We are treating them with non-hormonal prescriptions. And with infrequent bleeding and continuous non-cyclical symptoms, then we can consider the sequential combined monthly bleed HRT, and also the contraception. So after starting the HRT, monitor side effects and the bleed and adjust the treatment. Then depend on the clinical situations, we have the adjusting the dose is very important, and the regular follow and prompt referral to the other specialties if we not got any serious complications of HRT. And if the patient who having the intake uterus with less than 12 months amenorrhea, then the period-free HRT we can use that continuous combined Tibalon contraception. Again, monitor side effects and reviews. If the patient is having urogenital atrophy, then vaginal local estrogen is a treatment of choice. If the patient who having hysterectomy, then check whether both ovaries removed or the both ovaries intact. If both ovaries intact, usually we are not recommending the HRT. But doing FSH, and then FSH is more than the menopausal level, like 40 milliunits, and then we can consider the HRT. So these are the common preparations, oral preparations. We have conjugated estrogens. That is the best one we can use with a minimum side effects. Premarin is the best one. In tablet form, we have 0.3, 0.625, and 1.25 milligram tablets. And in developed countries, they have the transdermal patches and transdermal gel and other preparations also. Progesterone, only progesterone we can use in Sri Lanka, that is metroxyprogesterone acetate. So Provera, I think tablets available in some centers. or micronized prometrium, 100 milligram capsules we can use. And also, obviously, Mirena, it's a levonorgestrel IUS. Okay, combined continuous HRT. So what is combined continuous HRT? That means we are giving continuous hormone, and in between estrogen, in between we are giving the progesterone for the withdrawal bleeding. Usually every 3 months. So the preparations, so it's like oral, transdermal, and synthetic steroids also there. Tibolone. I think Tibolone is available in Sri Lanka in a strength of 2.5 milligram oral tablets. So simplifying decision, selection of HRT in a low-risk woman. Simply, perimenopausal woman, continuous estrogen, cyclic progesterone. Hysterectomized woman, estrogen only. Women with subtotal hysterectomy, estrogen only if no endometrium identified histologically at the lower section margin, or continuous combine should be used if endometrium seen. Endometrial ablation, either cyclical or CCT, combined continuations that depend on the if she is menstruating or not. Progesterone sensitive, Mirena plus systemic estrogen or micronized progesterones we can use. In early menopause, may require higher estrogen doses, and all the women start with lowest dose and adjust. Potential malabsorption, non-oral route is the best way to deliver the hormone. And postmenopausal low libido, try Tibolone as a first choice because the Tibolone have some effect on the libido. Non-responders to standard treatment, young with surgical induced menopause, subcutaneous implants of estrogen. Every 3 weeks, we can change the subcutaneous patches. Okay, so thank you for tolerating me. So for whatever the treatment, especially for the HRT, listen to the patient, suggest all available mode of treatments, discuss the pros and cons equally, let them to decide, and discuss the pros and cons again regards to choosing treatment, and discuss the follow-up plan and written reminders, and then follow up. Okay. Thank you. Thank you for tolerating me.
Right. Thank you, Dr. Suhajanan, for your very kind and informative lecture. I think the menopausal transition is an area. It's a gray area in I think in our undergraduate curriculum, and most of us don't have a clear idea about that. And I think this lecture cleared all our doubts because it was very informative. It was detail based, and all the information was given. And now let's go to the question sections. We have some questions which were submitted by the participants before the lecture commenced. Sir, there are about 3 questions. Is there a benefit in supplements to delay menopause, like the place of vitamin E?
Yeah. Okay. Thank you for joining me again. Yeah, I'm happy to answer the questions on vitamin E. Yeah, some sort of effect, compared with the placebo, some sort of effect is there. But the problem is vitamin E alone, we are not using for the menopausal hormone therapy or during the menopausal period or transition. But if it is combined with the evening primrose oil, yes, some preparations are there in the market in Sri Lanka. We can use, say, for example, there is a preparation called collagen E. So it's combined with vitamin E. And also the vitamin E has some of the benefits also in cardiovascular system. It's an antioxidant for the skin and things. So we can combine with the evening primrose oil. It has some effect on vasomotor symptoms.
The next question is, if patients were on a long-term OCP therapy, can they start on HRT? Any complications to be anticipated?
Yeah, actually, it's different preparations. OCP is for prevention of it's a contraception, but HRT, it's a hormone replacement. Both modality is different. But if the patient is on long-term OCP, depending on the age and the comorbidities, that's why I told. So 1-to-1 assessment is very important. After the careful 1-to-1 assessment, we can offer the HRT. No issue with that.
Okay. And in the chat box, I saw another question. What are the calcium and vitamin D supplements that are recommended during that period? Did you
Yeah.
experience?
Yes. I think there's some confusion about the bone metabolism and remodeling. So, as we know, there are two types of cells are there. So, osteoblast and osteoclast. Actually, osteoclast is responsible reabsorbing the bone, and osteoblast is responsible for bone reforming. So the balance is very important here. But with the aging process and loss of estrogen, there are few regulatory proteins are there, like RANG ligand and OPG proteins. These proteins are more or less depend on the estrogen concentrations. So when they have the high estrogen concentrations, the bone remodeling part is more intense. So more bone reforming. So that is very important for the woman's life. But in the postmenopausal period, what will happen because of we losing the estrogen concentration? So the OPG and RANG ligand and RANG proteins imbalances happen. So the bone is more towards to bone reabsorbing balance is tilted towards that. So in that case, the woman will losing a lot of bone. At the meantime, because of the aging, there are absorption problem happen, and their food habit will change, and also the taste things will change. So they are taking a lot of calcium deficient food and drinking water pattern and everything because of some urinary incontinence and those things. They are avoiding drinking water and things. So in that case, they might need a vitamin D and calcium supplementation. It may help, but I can't say it is the remedy for the HRT. HRT is different, but even in the HRT, if they have the calcium deficiency, it's no point, no. So the calcium supplementation may help.
Okay, thank you very much, sir. That wrap up today's session. I thank Dr. Suhajanan Tavaraja for his very informative lecture. Thank you very much, sir, for your comprehensive lecture. And I hope all of you have gained very good knowledge about the menopausal transition. And in the chat box, you will find the link to gain your CPD points and the online certificate. Please do fill that. And I hope you will join us with the next lecture on next Sunday and on the coming Sundays also, the CPD webinar series, in the CPD webinar series. Thank you very much.
Thank you. Thank you for having me. Thank you.